Good afternoon, everybody. I want to thank you for joining us for Look at What I Can Do, How to Advocate for Expanded Roles for Health Psychologists in Healthcare Settings, hosted by the Society for Health Psychology, Health Advocacy and Policy Council, and co-sponsored by the Society of Clinical Psychology, APA Division 12. My name is Matt Schooler, and I am one of the moderators for this afternoon's presentation alongside Jan Mooning. First, this and all SFHP virtual presentations are offered as a free benefit of membership in the Society for Health Psychology. Please invite your colleagues and students to join to ensure unlimited access to future presentations and other society benefits. Visit our website at societyforhealthpsychology.org for more information. This event is being recorded. Anyone who speaks during it, for example, to ask a question, is agreeing to be recorded and is granting permission for the recording to be posted on our website. The webinar is also eligible for one continuing education credit under the Society of Clinical Psychology Division 12 sponsorship. CE evaluation information will be sent via email to all who attend the full presentation shortly after the webinar. We will leave the evaluation portal open for 1 week until 5 p.m. Eastern on Thursday, June 22nd, 2023. CE certificates will be sent via email within 5 to 10 business days after the evaluation period closes, using the email of which you enrolled in this session. All participants are invited to submit feedback via the evaluation, even those not seeking credit. Questions will be taken at the end of the presentation. You can either submit them via the chat feature or you can use the raise your hand feature and I will call on you to ask your question. First, we will have a few slides to introduce us to the topic of professional advocacy, and then we will transition to our panel of experts for discussion on how they enacted this in their roles as health psychologists.
Awesome, thanks, Matt. We're happy to talk with you here today, and broadly, our goal is to provide introduction or orientation for folks who identify as early career professionals, trainees, or students to this process of advocating for expanded roles for health psychologists within healthcare systems.
And then at the end of this program, attendees will be able to at least list 3 potential roles that health psychologists can occupy within a healthcare system. At the end of this program, attendees will be able to describe how advocacy helps expand health psychologists' roles within healthcare systems. And at the end of this program, attendees will be able to assess at least 2 potential pathways, barriers, or facilitators they may encounter when attempting to advocate for expansion of their role as health psychologists in their setting.
The hosts, moderators, and panelists don't have any financial disclosures to make or any conflicts of interest to disclose for this presentation.
Today's agenda will consist of what can a health psychologist do, and looking at the variety of roles across healthcare settings that health psychologists can work in. We'll discuss how do they do that by advocating, shaping the roles of how health psychologists work in their respective healthcare systems, talking about why we should be advocating and the implications for understanding how health psychologists can improve healthcare systems. And we'll be discussing how do you go about and advocate and learn from the experts.
Yeah, absolutely. So we surveyed the Division 38 listserv just to ask about what different folks are doing in their settings. So as you can see, folks identified as being in a variety of roles from academic medical centers, primary care, counseling centers, correctional facilities. Folks that answered the poll were delivering interventions, providing interdisciplinary consultation, advocating for patients, and for us as health psychologists. So variety of roles across the board. I also want to acknowledge that this isn't a representative sample. It's just folks that happen to use a listserv that happen to respond to this survey, just to give us a sense of what folks are working on.
And then now we're going to talk about how do they do that. Specifically, we may need to provide education, orientation, information, or data to different healthcare systems so that we understand how to advocate for new or expanded roles for health psychologists in different systems. And specifically, as we're going to learn about today, advocacy is a skill that you can learn and practice.
Right. So why should you do this? Health systems that you're working in might not be aware of the range of services that you as a health psychologist can provide, especially as you're expanding in your career and going forward. You might be expanding services or creating new roles that health psychologists can do to improve overall patient care and outcomes. And we want to make sure that the health system is aware of that. And then ultimately, as you're redefining or reimagining what your role as a health psychologist looks like, this may help the health system get a better understanding of what services you're actually providing. So advocacy here is teaching others about what you're doing. And as your role is growing, helping them understand, why this is important to the healthcare system and what services it provides to further patient outcomes.
So how do we do that? Specifically, some points that would be really, really helpful is awareness of the health system and the structures and needs, and specifically understanding what the healthcare system is currently battling and addressing, and understanding how a health psychologist can come in and implement new skills and new strategies that might align with the values that the healthcare systems are working towards improving in there. It's also important to keep in mind that as you're advocating, to identify who the potential allies or partners are that could advocate for your new roles in different healthcare settings. In some of these roles, sometimes it's going to be directly working with physicians in different departments that are huge advocate for health psychologists who understand the significance of importance of integrating the psychologist into their particular department, and can really go to the administration showing how it will actually improve the quality of care for the patients that they care for on a daily basis. And maybe in some situations, they can use some of their own experiences of how having a health psychologist would actually be beneficial due to potentially conflict with challenging patients or dealing with just underserved populations that have limited access to behavioral health services because of limited availability. And then as we're going to talk about, you'll see there'll be a panel of experts who specifically who have lived with this and experienced and advocating for an expanded role for health psychology within their clinic and setting. So we are fortunate enough to learn from 3 different experts who have wonderful experience talking about how they got involved in their different fields.
Yeah, absolutely. So we have an awesome expert panel here today. We're really excited to hear from them about what they've experienced. Today we have Dr. Marwa Ahmed. Dr. Ahmed graduated with her doctorate in clinical psychology from the William Patterson University of New Jersey. She completed both her internship and fellowship training in clinical health psychology at Henry Ford Hospital, where she recently joined as a senior staff psychologist with the Henry Ford Cancer Institute in 2022. She specializes in the care of cancer patients and their caregivers. Today, we're also honored to have Dr. Antu Siegel. Dr. Siegel earned her doctorate degree in clinical psychology from Roosevelt University in Chicago, Illinois. She completed a predoctoral internship at the Milwaukee VA in Wisconsin and postdoctoral fellowship in health psychology at the Detroit VA in Michigan. She is board certified in clinical health psychology by the American Board of Professional Psychology. Currently, Dr. Siegel is an early career psychologist and works at Henry Ford Hospital in Detroit, Michigan, within the Transplant Institute, facilitating inpatient and outpatient pre-surgical psychological evaluations for liver candidates and living kidney donors. She is also currently the member-at-large representative for the Association of Psychologists and Academic Health Centers. Today, we're also delighted that we have Dr. Jennifer Farand. Dr. Farand is a board-certified clinical health psychologist with 20 years of experience in Hartford healthcare. As the program manager of the Institute of Living's Division of Health Psychology, she was responsible for developing and staffing a health psychology service line within Hartford Healthcare's behavioral health network. In 2020, she transitioned to a new role as a director of well-being for Hartford Healthcare. In this role, Dr. Farand guides the development and deployment of strategic initiatives to advance well-being for all who work at HHC and leads the team's research and educational activities. She continues to maintain a small psychotherapy practice and is particularly interested in helping individuals struggling with professional burnout and those seeking to transform their lives through healthier behaviors and better self-care. Yeah. So really appreciate having our expert panelists join us here today. And we'd just briefly like to start with sort of a general question that we hope will help you provide us with an introduction. So we wondered if the panelists could just tell the audience about a way that you've expanded or developed the role of health psychologists within your setting. You don't have to go in order, but if you'd like to, that's okay too.
I can go ahead and chat a little bit about that. So when I started my position as an embedded clinical health psychologist within transplant, I started the position about 2019, and I was in the role for a few months, maybe 4 to 6 months, when I realized that I needed to do a lot more than just the pre-surgical psych evals. I wanted to see patients post-transplant. So I was able to successfully navigate and advocate to reduce the number of evals, which was a big ask in transplant because we can't list patients unless we eval them. But I was able to reduce the number of eval slots to align with the hepatology clinic. So I could increase the post-transplant patients that needed to be seen and needed continuation of care.
Great, thank you so much.
I'm happy
Dr.
to go
Ford,
next.
please.
I started my role in the Institute of Living in 2005 as an embedded psychologist co-located in our transplant program and our surgical weight loss program. And it was almost a job of convenience because our surgical weight loss program had just arrived essentially at our hospital, and they needed a psychologist. And it just so happened that I was completing my fellowship in clinical health psychology in our preventive cardiology division. And I took this job. And so I was an N of one, starting to sort of develop the model for bringing health psychology services embedded in medical practices in our system. And, I was in the role for almost 18 years. And what ended up happening is that we really sort of showed that having a co-located psychologist in a medical practice was good for not only the patients, but it was also good for the providers and the staff. And we really used that experience mostly from qualitative data and feedback to negotiate for broadening the role for psychologists in our healthcare system, really figuring out how to operationalize this in our healthcare system, and then showing the return on investment to support growing the model into other practices, especially those where psychologists are nice to have instead of places where psychologists really ought to be located for like regulatory reasons. And so by the time I exited the role, we had grown the division from one psychologist to 17 psychologists supporting a number of service lines and medical areas in our healthcare system, starting with one hospital, growing our footprint to 7 hospitals in our acute care settings.
Oh, awesome.
Thank you so much.
I am sorry, I'm having a difficult time
That's
navigating
okay.
my
You
audio.
are.
Okay. Oh. Sorry, can you guys hear me?
Yes, I
Yes, we
can.
can
Yeah,
hear
go
you.
ahead.
Perfect. Sorry about that. Hi, everybody. So I can speak a little bit about how I expanded my role. Initially in October of 2022, I took on the role of a general psych oncologist within the cancer center here at Henry Ford. So basically, the responsibilities were really just those of a general psychotherapist, so that they needed somebody to cover outpatient work, given that there was so many referrals coming in from all the cancer disease sites within the cancer center. And so they wanted somebody to mainly do outpatient intakes and psychotherapy. I felt that while that role was wonderful because I really enjoyed oncology, I felt that that role wouldn't really capture all the services and just the services that health psychologists can offer within oncology care. So what I did was I advocated with my manager, evaluating several disease sites as possible specialty or integration areas. I looked at the work queue where all the referrals sit, and I realized that there were hundreds of referrals coming in from lung and neuro-oncology, so brain and spine cancers that were just not addressed, and probably would not be addressed for the next 2 to 3 months, just given the number of referrals that were sitting in there. Looking at the statistics and looking at the need of these populations, I advocated to reduce the psychotherapy load that I was taking on and dedicating 2 half days to a specialty clinic. And I ultimately took on neuro-oncology as a specialty clinic, and now I'm the health psychologist embedded within their team. I'm not just doing psychotherapy anymore. I'm also doing capacity evals, cognitive testing, kind of bridging patients from psych-oncology to neuropsychology if needed. also doing family meetings to discuss and address the different expectations that family members have after somebody has brain or spine surgery. And also doing pre-treatment evals to assess for any psychiatric or substance misuse issues that would interfere with treatment adherence.
Awesome, thanks.
Thank you so much. So another question I wanted to ask all the panelists that we have today is, what were some of the barriers that you experienced as you were encountering and advocating for these different roles? All of you have done a fantastic job advocating, but obviously I recognize there were probably some barriers. So what were some of those barriers that you came up against when advocating for these new roles and these different positions you're currently doing and did previously?
So I can start off. So one of the barriers that I encountered, and I still encounter to this day, it's a work in progress, is the clinic space. So those of you that work in a hospital know that space is a luxury. And so knowing that I need to see a patient after a hepatologist sees a patient, the scheduling is a huge barrier. I don't have any additional admin help to do those things. And so that sometimes can be a big barrier for getting patients in, calling them, scheduling them, et cetera. And sometimes it seems like a small thing, but in a busy clinic where, like today, we had 4 hepatologists, each seeing like 10 patients in the span of like 2.5 hours. You need a room and you need to find a room, and there's no rooms. And so it makes it a little difficult. So I think that's one of the initial barriers when I started advocating to expand my role in the post-transplant sphere. Where are you going to see these patients? How are they going to get scheduled? How do they get put on your schedule clinically? They're small things, but at the end of the day, they kind of become huge barriers for time and resources, staff resources specifically.
Thank you for that.
One of the barriers that I'm sorry,
Go ahead.
Okay, I'll just go real quick. So one of the major barriers that I encountered was mainly related to directly working with physicians and surgeons. Because I'm in the neuro-oncology clinic, I'm working with neuro-oncologists, neurologists, neurosurgeons. So people who may not be directly associated with psychology, or maybe they haven't worked with health psychologists in the past. So I really had to spend a lot of time educating them on what health psychologists can do beyond psychotherapy. And this too is still a work in progress. Initially, the referral pathway was a bit slow because it only included referrals like adjustment, anxiety, depression related to the cancer diagnosis. But now we're working our way up to getting more referrals for capacity evals and the other services that I mentioned earlier.
I would share that I've experienced all the barriers that have already been mentioned. And also for us, funding was a big one, right? Like nobody really wanted to pay for a psychologist or provide the psychologist office space or admin support, or even build us into the medical record that was being used by the medical practice. There was also a general sort of can be a lack of leadership buy-in and lack of awareness and understanding about health psychology as a discipline and the ways that health psychologists can be beneficial both to the for day-to-day immediate sort of healthcare patient care needs, but also to the growth and development of the healthcare system at large. And then the last thing was my own lack of knowledge and experience in healthcare administration and finance, because these were things that I'd not been taught in graduate school and was really not prepared to deal with, particularly when having to sort of make a business case for why this can be really beneficial when the benefits from a financial standpoint might not be felt by the organization for years.
Yeah, absolutely. Thank you so much, Dr. Brennan. We're getting a question from the audience. I think we'll turn to that one next. This question says, how do you make the financial argument to the institution given some of the low reimbursement rates for psychology services? I think this dovetails really well with the discussion that we've been having, and I hope can hear about not only the financial argument, but I think some of the other aspects of data or information that you thought might have been helpful in advocating for this.
So I can start by saying that the way I've thought about this is that there's a lot of ways to make the argument, and I've thought about it from the standpoint of there's a moral argument, there's a tragic argument, there's a financial argument, and there's a quality of care argument. So the moral argument is that it's the right thing to do. If we're concerned about the triple or the quadruple aim, or we're concerned about patient care and access and affordability and equity and excellence, then we ought to have health psychologists in leadership roles in our healthcare systems and providing direct, on-site day-to-day patient care. The tragic argument is that if we don't put health psychologists into our medical practices, then patients die by suicide. And we have lots of examples of that in our healthcare system, and I'm not afraid to bring them to the table when I sit with leaders, because we don't want that to happen on our watch. The financial argument, like I said, is a little bit harder to make, but the way we've sort of tried to spin this is that we think that, the financial benefit to the organization might not be seen for a long time, but the day-to-day benefit to, like, a physician can be felt immediately. Because if a physician isn't, spending their time addressing behavioral health needs, they have a partner in the office who can help them with that, then that saves them. It protects their time, it lets them do the things that they're hired to do, and it sort of more fully integrates the psychologist into the practice. And then the quality of care argument is pretty easy to make as well, using metrics that the organization already collects, particularly about the patient experience and patient satisfaction in our outpatient practices and our inpatient practices.
Fantastic. Thank you so much for sharing that. I appreciate that. Dr. Segal or Dr. Ahmed, either one of you have anything you'd like to add?
I could add, the creation of putting together an R01, right? What's the cost benefit to a new position can be very challenging, like Dr. Farard said, and we don't get trained on how to do it. And so a lot of us in this space have to learn from each other and learn from what's done in previously. So, as an ECP myself, I'm interested in learning more how to do that because I want to be a leader, right? I want to be in those spaces. I want to work, hopefully, in more administration at some point in my career towards towards the later half. But we don't get taught how to do those things. And so it can be a big barrier because we are in the role of prevention. And we do a lot of preventative practices. So one of the ways I can advocate for expanding my role is by saying, okay, we're going to prevent, hopefully, non-adherence to medications for our transplant patients who are on lifelong immunosuppression. And these are the ways that I can implement strategies within the clinic, or these are behaviors that you can look out for, educating other providers. And then that sometimes, if they find value in that, if you have a division head or a section head that finds value in what we bring, sometimes the financial discussions maybe are a little easier. I think it's still really difficult, but if they find value in what we do as clinical health psychologists, what we bring to the table, that's a huge talking point and sometimes can help out with some of the financial issues.
Yeah, I would agree with everything that's been said already. I don't have much to add other than just what I found to be helpful while expanding this role was to just look at the metrics. We have something within the system called PROS, which is basically like patient-reported outcomes. Every time a cancer patient is seen in the clinic, they are asked to complete the PROMIS measures. If anyone is familiar with those, they're very good at detecting issues with quality of life, fatigue, depression, anxiety, and so forth. And even though many of the patients score very high on at least one of those domains, they're often not seen by psycho-oncology just because of the limited access and lack of awareness of our services. And so that's one way that I've been able to advocate, is to help somebody within the research department help me to pull that data, look at the results of the PROS outcomes for the past 6 or 12 months, specifically look at the results of patients who have not been seen by psycho-oncology, and take it to leaders and say, here's the amount of people that have yet to be seen or have reporting scores within the moderate to severe ranges, and here's what we could benefit by expanding psych-oncology to these specific populations or to these specific patients. And oftentimes it really comes down to the quality of life and helping them adhere to treatment a little bit more to make life for physicians a lot easier.
Very
Yeah,
cool.
absolutely.
Awesome.
Thank you.
Thank you so much. Another question that I want to ask you guys is, when it came to looking for advocating, what gave you the idea to advocate for making these changes or expanding these roles? How did you guys make these decisions and identify people to speak with about making these decisions?
So I think part of my, I guess, light bulb that came on after I took on the role was to see what other transplant institutes were doing around the country. And so I dove into the psychological research, did a few, PubMed type of searches, what is being done post-transplant, because I saw a need just clinically, right? I see the need in the patients. Well, what's being done at other centers around the country, and can I glean from those experiences? And so there's a lot of great research, particularly in the cardiac space, for post-transplant care and helping patients adjust to this new life, which is very different for a lot of post-transplant patients. Being immunosuppressed is not easy. And so there's a lot of good literature. And I think that was the biggest thing that I used to say, hey, this is how I want to craft things, because this is how it's been done at a few other centers that have done well, and they have shown research to or data points to say why it's beneficial. So that was a good talking point and a good source of information as to how I thought about it and created it.
I'd say for me, I was in this role for quite a long time, and I remember in the beginning I felt very intimidated by doing anything other than clinical work. Right, I felt very comfortable doing clinical work, but I would be in these sort of administrative meetings about, like, how do we get paid for the clinical work and billing and insurance stuff, and none of that all scared me a lot because I didn't feel comfortable or competent with that terminology and that level of sort of like strategy and planning. But I would say that as I got further and further in the role and became more comfortable in my system, I really saw an opportunity and a need for us to do a better job with integrating health psychology into our medical practices. And I eventually got comfortable enough, doing the general clinical work, that I started being interested in a new challenge, and program development started to become really, really just an interesting new challenge to tackle, and the rest just sort of happened just in the process of developing relationships and going into new practices. Because what happened is that we ended up building a really successful program in our transplant department, and then other departments in the hospital started to say, well, we'd like a psychologist too. Can you help us figure out how we can do that? And I was always sort of eager to be that person to have those conversations and do that creative work of figuring out how we can operationalize this in our system. So that's kind of how it happened for me.
For me, it was a little similar to what Dr. Siegel had done. I had really dove into the research after looking at the work queue for the psycho-oncology referrals and seeing that lung and brains and spine patients were the ones who were most referred, but unfortunately not addressed. I looked into the research and saw which of these populations are most in need. Is there a time crunch on any of these populations? Is there something that we need to address sooner rather than later? And in that research, I learned that some of the brain cancers, unfortunately, have a very short and limited survival time, specifically glioblastomas. Their survival time is usually like between 12 and 18 months. And so I used that as my argument, using from the literature and talking with the neuro-oncologists, saying these are the types of patients that we really need to address and prioritize in our referral pathway. And so I was able to dedicate specific hours throughout the week only for glioblastoma patients. And during those hours, I even dedicated like smaller portions of time only open for warm handoffs in case something happened in the clinic, somebody needed to be seen right away for adjustment after they were recently diagnosed, or family was having issues with adjusting to the glioblastoma. I was called right then and there within the clinic. So ultimately tied back to the research that there was a lot of need within the clinic services after we brought this to everyone's attention, and it's been well used thus far.
Awesome. Thank you so much. That's really helpful. Appreciate you all sharing, some of what came up for you and the interest that you had. I think that also makes me wonder, we talked a little bit about barriers. What were some facilitators? And it could have been, something that happened, some data that you found, kind of like you mentioned with research on outcomes or things that helped you advocate, or it could even be a person, like an ally or someone that you had in your clinic or in your team that helped you to do this advocacy.
I can speak to that.
Oh, go ahead.
Oh, sorry. I just wanted to say that the person who would later become my manager was the person who was my biggest facilitator and biggest supporter in this. At that time, when I joined in October, we had about, I think, 4 other psychologists and 1 therapist within the psycho-oncology group, and all of them were generalists. And her and I spent a lot of time talking about the need for specific disease sites and integration for health psychologists within specialty clinics. And so she was very on board for that. Like I said earlier, I brought in the research from the pros and from the literature as to how much need there is within the neuro-oncology team, because that's what I wanted to integrate with. And she at that point helped me connect with the people that I was interested in working with most. So she sent a lot of emails on my behalf, trying to make connections for me and introducing me to the teams as the newest member of the psycho-oncology group. And at that point, she had also asked the teams to invite me to come and observe and evaluate their clinics and just observe, shadow the neuro-oncologists and neurosurgeons as they worked. And they were very welcoming to that. And I don't think that any of that would have happened without her help and her support in facilitating that process for me.
So I was going to say something similar. So I try to think about who is going to help me advocate for this, since I was new to the position. And I was essentially revamping how my services were going to be delivered. It was a little scary to do, particularly as an ECP. And so I wanted to have people in my corner that were going to help advocate for us. So we have a section head, a health psychology section head, and discussed with her kind of my thoughts about how to change this. Luckily, she's also one of our transplant psychologists, so she understands the group, which was really helpful. And then we thought about, okay, well, who else can help advocate for this if we need, more like power to it. So then it was having a brainstorming session a few different times, thinking about, okay, here are some pros of increasing the post-transplant clinic availability and helping with, mood-related issues, adherence issues, social support issues, and substance use issues post-transplant. So there's a great need. And so kind of putting that all together in like a 1-page document and then sending it out to the hepatologists or the key stakeholders and saying, hey, like this is something I've been thinking about doing. I know I'm new to this role. I'm still getting to know the team. And I wanted to send this out to you guys to get feedback. What do you guys think if I do X, Y, and Z? And so it was engaging the stakeholders in a conversation with an outlined, 1-page plan that was to the point, that said, what I wanted to do, how I wanted to do it, and what I thought the benefits would be of that. And having that conversation with her was really helpful, because I got, a lot of the support that I needed, but also helped brainstorm. And then when I felt more confident in reaching out to the larger group, which I think is a big deal when you're asking for a difference in what you want to do. Sometimes the confidence needs to be front and center so that it could be more powerful.
Yeah, I absolutely agree with all of these comments. And for me, what I would add is that getting the right education was important. And also getting board certified was important. That helped sort of raise the, I don't want to say made my work more legitimate, but it elevated the status of health psychology in my system, because our physician collaborators understand what board certification is. And also it was a helpful experience for me as a psychologist to go through that process and be certified by my peers. It really helped a lot in terms of my confidence to do the work. I can give the example that when we built our primary care behavioral health program in Hartford Healthcare, I hadn't had much any experience really clinically in the primary care setting. And so I found a certificate course at UMass, which still exists for primary care behavioral health, and I would highly recommend it. It's a wonderful program, and it gave me everything I needed to both be able to do the work clinically and guide the development of a program for primary care behavioral health in my healthcare system. And then we involved the right stakeholders to help us educate our staff. So we hired a bunch of clinicians to put in our primary care practices. And then we partnered with the APA and Barbara Ward Zimmerman, who I'm privileged to have a relationship with. And Barbara came and trained all our clinicians on how to do PCBH in our healthcare system. And that helped a whole lot. But also the other thing I would add is that on a personal level, for me, what's been really helpful is not only mentorship, but also coaching and sponsorship, and understanding that there are differences in terms of those different sort of types of relationships, right? Like I have mentors within my system who have been in the system for a while, who are leaders and who know what I want to do and can help me accomplish those goals. I have coaching with people outside the organization who are also outside my discipline, who can help guide me around some of the sort of like the financial questions and the ROI stuff and the business case stuff that I don't know a lot about. And then I have sponsorship. I have leaders in the organization who are willing to sort of put their reputation on the line and who trust that I can do this work and that I can sort of help lead this work for the organization. And that took a long time to find and develop those relationships, but they've really been integral.
Awesome. Thank you so much. Other thoughts or comments about this before we keep shifting? Yeah, thank you. I also wondered, and this might have come up some in the conversation, but just kind of summarizing for folks as we're approaching the end of our time together, what was something that you wish you had known before you started this process of advocacy? As you're reflecting back on coming through this journey, was there something you wish you had known at the very beginning that someone had told you, or something that you wouldn't, kind of like a one sentence takeaway that you really encourage for other folks as they're approaching this?
I'm a little bit reluctant to say this, but I'm going to say it anyway. I say this a lot to others, that one of the things that really helped me was that I had this attitude that I would never say no to anything. I've always taken all opportunities that were given to me and that I could sort of find. And the downside of that is that you end up being really busy, and it can sometimes be an impediment to your quality of life. So there's a balance there, but for me, really taking every opportunity and saying no to nothing in a measured way would be sort of the main take home for me.
Yeah, thank you. That's great advice. And it sounds like that balance is really key, trying to understand when to say yes and when to maybe hold off.
Yeah, this is a really good question, Jan. And I still want to reflect on it and think about it. But I think the first reaction, or the first thought that came into my mind when I heard you say it was just like, I wish I I mean, we always wish that we know more. And I think one of the biggest things is like, I wanted to maybe talk with someone who has actually gone through that position and expanded their roles. You know, we brainstormed things and we talked about it, you know, with my leadership, but I wanted to maybe talk with someone through what were some of the pitfalls, what were some of the barriers, and then maybe we could have problem solved a little bit better. So it's kind of just like my initial thought, but I think it's a really good question because looking back, maybe things could have been smoother or easier, less stressful on me, the clinic staff, the patient. You know, sometimes things feel really stressed and rushed, and we don't want that to be the case when we're delivering interventions. And so I think there could have been, and there still is, a lot of room for improvement. I think one of the things I wish I had done maybe was to talk with someone one-on-one that had actually expanded this role and kind of just brainstormed and problem solve the barriers that they had gone through.
Yeah, absolutely. I think that lived experience is so important. And I think that's why we're so appreciative of you all for coming to share with us today. Yeah, Dr. Ahmed, anything you wanted to add?
No, I feel very similarly to Dr. Siegel. I think I did think to reach out to somebody, but I think a little too late. So I actually made connections through ACLP. So that's the Academy of Consultation Liaison Psychiatry, because that's kind of what we were doing in the psycho-oncology group here at Henry Ford. And so I went to that conference, and I also made connections through MPA and found that a couple of people who work in neuro-oncology. However, I think it would have been really helpful to make those connections sooner before I developed the role or expanded my role, rather than while I was doing it or after the fact. It was really helpful to hear these people's experiences, and they were very open with meeting with me via WebEx because they're all over the country, but very helpful nonetheless. I just wish I would have learned from them a little sooner. I think that would have saved me a lot of stress and time, kind of like what Dr. Siegel said. And also another thing that I found to be really helpful was having a mentor. So I feel like no matter how early career or how late career you are, it's always helpful to have a mentor, somebody who's more experienced or is very similar, has similar mindset, but is maybe more experienced than you are. And luckily here in Michigan, we have the Michigan Psychological Association, and we have the opportunity to either be a mentor or a mentee or both. For somebody within health psychology, and I was lucky enough to be paired with somebody who is a health psychologist with about 20 years of experience, works in a similar healthcare system, has a lot of experience with things that I have not encountered just yet, and we meet on a monthly basis. And so bouncing ideas off with him has been extremely helpful as well. So I think that's a take home for me, is that I wish I would have done that a little sooner as well.
Awesome.
Thank you so much. I'm recognizing what time it is, and I want to thank everybody. I want to thank the panelists for their thoroughness and responding to our questions. I also wanted to open it up for the audience to see what other questions the audience may have that the panelists may be able to answer for us today.
Yeah, and you can use that raise hand feature down at the bottom, or if you would like to, you can type it in the chat. I'm happy to read it out loud for you.
We have a question from a Dr. Chelsea Neal. Chelsea, would you like to unmute yourself?
We're not able to hear you. I don't think it's unmuted.
Here I am going on. Okay, thank you. Yeah, I don't exactly know who had mentioned this in the beginning, and so I apologize, but somebody had mentioned patient outcome measures as a way to kind of show evidence of the impact that we have on patients. I work as a consultation psychologist in a big system, but a small hospital in Pittsburgh. And we really run kind of floor to floor throughout different departments. And we are constantly trying to grow ourselves and kind of carve out spaces within these departments. What other possible outcome measures would you recommend we look at to support our data and so kind of support our cause, to bring to these departments heads and say like, hey, yes, you need more of us. You need us more than one day a week in your clinics and things like that?
Oh, sorry, Dr. Ahmed, we cannot hear you just yet, so you might have to unmute your phone.
Sorry about that. I didn't realize that I had not done that. I'm sorry. What I was saying was, Chelsea, that was a very good question. And just off the top of my head, I think we had looked at multiple different types of measures like the PHQ, the GAD-7. Obviously, those are just typical measures that we use in behavioral health, but we realized that those are not good measures within the health psychology system, specifically because they don't really identify specific experiences within cancer specifically, I guess, for us. I found that the PROMIS measures were a lot more helpful because they could identify both physical and mental health symptoms within a medical population. And that is something that we've been using more regularly than the other measures that could be found regularly within behavioral health. I like the PROMIS measures because they don't just look at anxiety and depression, but they also look at a whole host of issues like fatigue, quality of life, physical stamina, a whole host of questionnaires. I think we only have about 5 or 6 that we administer to our patients in clinic, but I am scheduled to meet with the patient-reported outcomes team sometime this month or next to see if we could include more measures and if we could facilitate an easier way to pull this data so that patients' issues are addressed more consistently and regularly.
That's fantastic. Do you do that like through your medical record, or do you do that? Oh, yeah. Do you do that through like paper? Because I know in like the hematology and oncology, they do it like paper and pencil, and then they like find us in the hospital and like hand us this paper, which is not helpful. And then the other follow-up that I have is that, do you do any of that pre and post psychological intervention, like when they come into the department and then after they meet with one of your team members?
Yeah, those are great questions. So yes, some departments unfortunately still do the pen and paper, which is very not helpful. Also, the paper trail is just sometimes hard to follow and it gets lost in the mix. So what we've been trying to do and advocating for more recently is to have every single patient be assigned these PROMIS questionnaires before their first visit or during their first visit. And oftentimes one of the MAs or the nurses will give the patients either a computer or an iPad with all the questions on it, and they'll fill it out while they wait in the waiting room until they're seen. And then automatically all of those scores of the questionnaires are pulled into their electronic medical record. And what we're trying to advocate for is that they're pulled into every single visit. So like the note for every single visit they have, regardless of whether it's with a behavioral health provider or not. So whether they're seeing hematology or a neuro-oncology, their PROMIS questionnaire scores are still going to be pulled into their note. That way, if one person misses it, another person won't, and it'll be seen more readily to people within the system. And then your other question, I'm sorry, I don't think I caught that. Would you mind repeating the second one?
Oh, absolutely. I just curious about pre and post measures after they meet with somebody on your team.
Yeah, so up until I believe a month ago, we were not doing that, and we as a team of psych-oncologists advocated to the cancer center that it would be helpful to have pre and post. So now we're facilitating a process where these questionnaires are either sent through my chart or administered in the clinic before they see us, initially when they see their initial cancer provider, and then when they see us and then again after treatment is completed. But this is obviously still a work in progress, and we still need a lot of people on board for that. But that is the ultimate goal, and unfortunately has not been done until this point.
Thank you so much.
I was thinking as we were talking that some of the things we've looked at in addition to patient-specific outcome measures or pre and post measures, I mentioned this earlier that we look at patient satisfaction as well, right? A lot of our practices use Press Ganey as a patient satisfaction survey. We found this doesn't exactly meet our needs, so that in some of the programs that I've worked in, we've created our own patients, like our homegrown little patient satisfaction survey, and that's a really great way to obtain qualitative data from patients about their experience with our programs. We also use things like time to first appointment. So like in the primary care setting, if somebody can't get an emergency, sort of a crisis visit within 24 hours with a clinician, then we know we don't have enough staff, and this is a way to argue for hiring more people. We also can look at things like ED visits, like in theory, and when behavioral health is intervening with patients, then they're touching the healthcare system less in other ways. Maybe they're not going to the ED as much. Maybe they're not calling up the provider as frequently. Maybe the provider isn't overwhelmed with like lots of messages in their in basket from the patients who need a lot of help, right? So to that point, we can sort of let provider satisfaction be a way to sort of make the argument or justify the need to bring more behavioral health providers into the practice as well.
That's awesome. I didn't even think about some of those ED measures and things like that, follow-up visits in general. I work in a surgical clinic 1 day a week, and I think they would be amazed at the amount of times they see patients versus after I see them. So thank you.
Mm-hmm.
Thank you for the responses. Another question that popped up is, during the work we're advocating, did you also develop different programs for support for yourselves, or are you already using existing programs in place, such as like self-care support groups, emotional support groups, maybe venting support groups, or groups where you can voice like frustrations or so forth? You're kind of working on advocating and maybe coming up against some challenges or barriers along the way.
I feel motivated to take this question because this is my entire job now, right? So I mentioned this, but I didn't talk too much about this. In my system, we've invested in a well-being department that focuses on clinician and healthcare worker well-being. We have a system of 38,000 employees, and so we have a lot of work to do. And the pandemic gave us a really good opportunity to do this work because it brought a lot of national attention to the crisis of healthcare worker burnout. So we're trying to figure that out, and I can say that it's not easy, particularly for behavioral health workers. And what I've noticed in my own system and have tried to advocate for in my own system is that our system is turning to our behavioral health professionals as really the ones who should meet all the behavioral health needs of not only our patients, but our workforce, right? So like we have a huge behavioral health network in my healthcare system, and our healthcare system wants our behavioral health network to be the ones that offer support groups for our workforce and help the workforce with burnout. We can't possibly do that and take care of all the patients and take care of ourselves too. So we're really working on being innovative and creative about the ways we support people and educate our staff around caring for self and caring for our colleagues, and doing it in a way that is sort of consistent with the values of the organization and thinks about our staff as being patients too. Like we're all users of the healthcare system as well. We shouldn't be the ones that are having to sort of like meet our own needs for healthcare and meet the healthcare needs for everybody, all the patients too. That's not well said, but I'm just kind of pointing out that it's a big issue.
I was going to add a little bit about what we do and what I find helpful. So within our division of health psychology, I think there's about 18 or so of us. We meet once a month as a group to talk about programmatic things, which I think is really helpful, because we need to know, what's coming down that we're going to have to know how to do and address. And brainstorming as a group is really nice. In addition to that, our wellness officer here at Henry Ford has instituted this program called Connect the Docs. And so it's essentially like a social hour, and we do it once a month. We do some during the day, like at a lunch hour, or we do something like after work, like a happy hour. And I found that to be really beneficial because that's more of a, hey, how are you doing? Let's touch base. And I think that's really important for those connections because there's so many of us here at Henry Ford, but like, I never see Marwa all the way over at the Cancer Institute. And so it's nice to see people and then spend time with them. And in addition to that, we actually have a smaller group of just the transplant psychologists that also meet once a month. And so it's like I have a small group that I meet once a month within my own like health psychology transplant, the larger health psychology group, and then a social hour. And I found that all to be really helpful and beneficial for my own well-being.
Yeah, absolutely. Thank you so much for these really helpful comments. I think it's important to learn and develop that way to take care of ourselves as well. And it sounds like community is a big part of that. And recognizing that there is a need is a huge part of that as well. We really appreciate you all taking the time to join us. We very much appreciate our panelists for sharing their awesome expertise with us and helping us learn a little bit more about the awesome work that they've done, as well as how we could undertake some of this work ourselves. I know there was a question about resources earlier. I think some of the panelists are willing to share any resources. So if there are links or things you want to drop in the chat, or we can certainly ask Barbara to help us send them out over the listserv after we're done with the webinar today. So either one is fine. We're hoping that we'll get connected with some of those today. So I really want to thank you all once again for attending this discussion today. If you would like CE credit for attending this event, we just want you to remember to respond promptly to the evaluation link, which will be sent via email shortly after the presentation today. We'll leave that evaluation open till Thursday, June 22 of 2023. So that's in a week. And the CE certificates will be sent via email within 5 to 10 business days after the evaluation period closes. Remember that you're encouraged to submit an evaluation, even if you're not seeking credit. Feel free to email us at apadiv38@verizon.net, and I'll put that one in the chat as well. And we also want to make sure that everyone is aware that you can join us for 3 full days of programming and networking events at the APA convention in Washington, D.C. That's August 3 to 5. And then I see that some of the panelists have left their contact information in the chat, so we really appreciate you being open to folks contacting you. And we thank you again for your time.